Hello, once again, good afternoon to everyone. And thank you once again for joining us for today's session. I am happy to introduce our speaker for today's work session of the Global Critical Care Fellows Seminar Series 2024. Our speaker is in the person of Dr. Tariku Soboka. Dr. Soboka is an assistant professor of anesthesiology and intensive care medicine. He is the head of intensive care unit at Axon Stroke and Spine Center and an adjunct staff of the St. Paul's Hospital Interdepartmental Division of Intensive Care Medicine. He is a seasoned fellow and trainer from our Ethiopian team, and he's going to bring us teaching for our fellows on biomarkers for fungal infections. We know that sepsis is responsible for a high burden of both morbidity and mortality in our hospitals, being responsible for 1 in 5 deaths and as much as over 11 million deaths annually globally. A good chunk of these deaths and morbidities occurring in low middle income countries, specifically in sub-Saharan African countries. A lot of the time, bacterial infections are identified as the major cause of infections and sepsis, but fungal infections are not uncommon, and in most cases are sought after quite late when the patient's outlook or prognosis is very poor. Dr. Soboka is going to discuss with us today what are the biomarkers that are available for early diagnosis of fungal infections in our critically ill patients, and then give us insights onto how we can utilize this to improve the outcome of our patients. Dr. Soboka, your audience. Just before you come on board, let me just again, the house rules, remind everybody of the house rules. Kindly keep your mics on mute during the presentation. At the end of his presentation, we would have enough time to solicit for questions and contributions from both the fellows and audience and others who are joining us. During the presentation, if you have any question, just so that you do not forget them, kindly put them on the chat. We will take note of them. We will read those out during the question time. And if there are any other clarifications that you would want during the question time, feel free to let us know. By raising your hands, we will unmute you, or you can type into the chats if you have difficulty accessing us verbally. Thank you very much. Welcome once again. Dr. Soboka, over to you.
So, thank you, Dr. Chris, for your introduction. I hope I'm audible.
Yes, we can hear you.
Yes, Tariku, you are.
Okay, thank you. So, good afternoon or good morning again. So, today's topic to talk on is about biomarkers for fungal infection, especially specifically for patients who are admitted to ICU or in critically ill patients. So, as Dr. Chris has introduced, my name is Tariku. I practice both in the government and private hospitals. So I'm going to take a few minutes from you to discuss about these interesting topics and also relevant topics while managing patients in the ICU. So regarding disclosures, there is no conflict of interest regarding these presentations. And these are the 3 learning objectives I have. At the end of this session, fellows will be able to describe fungal infections and also the burden of this fungal infection in critically ill patient. And at the end, you will be able to identify also challenges for diagnosing fungal sepsis and treating it. And also you will be able to list common and relevant biomarkers which are important for the early diagnosis and initiation of therapy in case of fungal sepsis. So as outlined, these are some of the outlines of my presentation. We will see a few points on the introduction. We will see challenges regarding managing patients with fungal sepsis in the ICU. And we will see common biomarkers one by one, not all of them, but common biomarkers that are being used in the medical practice currently. And we will see their clinical implications. And finally, we will summarize and finish our talk for today. So as introduction, fungal sepsis is one of the common things especially currently come into picture while managing patients in the ICU. So especially the Candida species are the commonest fungal agents which will result in infection, and it accounts about 20% of infections in the ICU. This is quite significant number. So the incidence of invasive fungal infection is also currently increasing. As you know, earlier invasive fungal infections are common in immunocompromised patients, but nowadays, even in not in immunocompromised, but also in immunocompetent individuals, invasive fungal infections are coming into picture and needs attention. And when we see the mortality, the 28-day crude mortality goes as high as 40%, in some studies up to 50%. So generally, the mortality associated with fungal infection in critically sick patient is quite high. Why the mortality is high? We will see in the next few slides, because there are several challenges in diagnosis, in treatment, and follow-up for those patients who are developing fungal infections in the ICU. So when you see this map, it was one from the paper which was published in the International Journal of Fungal Study in 2017. And it is just to show how fungal infection is common, but data are lacking regarding the burden of these infections in critically sick patients worldwide. So when you see the blue colored one, that some parts of North America, this in 2017, and also some parts of South American, most parts of Africa, Asians, and parts of Europe, there was no data regarding how common and what is the burden or the cost that fungal sepsis is resulting in ICU. So the green, the light green one, as you can see, again in most parts of North America, Canada, and again South America, and most parts of Europe and Asia. As you can see, the papers were available, but when you see the national data and as a continent-wise, there was again papers lacking or data lacking, and the bright green one in Australia, India, China, and some parts of South America again. And there are some abstracts available, but this is to show that how data are lacking regarding how common fungal infection is in the ICU, what is how much mortality or morbidity is associated with fungal infections in the ICU, and not only in the developing country, even in developed country, these things are coming into picture currently. But a few years back, we were focusing mainly on bacterial sepsis than fungal sepsis, especially in immunocompetent individuals. But nowadays, fungal sepsis is also becoming more important. So what are the challenges we have regarding managing fungal infections in the ICU? One is delayed antifungal therapy. So as I said, especially in immunocompetent individuals, when the patient is coming with a feature of sepsis, having fever, hemodynamic instability, oxygen requirement is increasing, patients are having multi-organ dysfunction epidemiologically. So we are giving attention first for the bacterial sepsis, which is right. But usually we don't consider fungal sepsis as early as that of maybe bacterial or viral, especially in a few years back. But now the fungal sepsis, especially for those patients who are not responding for potent and broad spectrum antibiotic, is one of the time to consider fungal sepsis. So one is the delayed antifungal therapy initiation is one of the things which will also increase mortality in hospital. The other things are regarding blood cultures. Blood culture, as you can see from different samples, the yield is around 50 to 70%. So 30 to 50% of the case, there may not be positive blood culture. And not only that one, the time to positivity for blood culture is longer than that of bacteria. It may take more than 7 days to arrive. Nowadays, there are some modification in lab and advancements in technology, but still it takes 5-7 days again to get blood culture to be result for fungal infection. So it takes a longer time. So if we don't start antifungal earlier, so we are going to lose these patients. The other thing is, again, empiric therapy, as guidelines are recommending. But the issue with empiric therapy is one is the resistant issue that fungal agents are developed. I mean, the fungal species are developing against fungal antifungal agents. And the other thing is sometimes we may not be treating proper species with proper antifungals, so that may also predispose for resistance. So all these things are some of the challenges that we have with patients who have fungal infection. So delayed initiation of antifungal, the issue of blood cultures taking a longer time to result in to show some kinds of growth or no growth, and the empiric therapy, which may result also in resistant of fungal species to antifungal agents are some of the challenges. So in terms of diagnosis, there is a challenge. Once we diagnose, again, the availability of the antifungals, the side effects, the issue of resistance, all those things are the challenges. Another issue is in resource limited setup. Resource limited setup by itself is another challenge. If I raise the issue in my country, Ethiopia, so most of the potent antifungals, especially ecocandins and from azoles, especially voriconazoles, in the IV forms are not easily available. And even if it is available, it is quite costly, and most of the patients may not afford. So most probably, most of us, especially who are working in resource limited setup, will share the same challenges. So these are some of the challenges that we have for treating patients with fungal sepsis in the ICU. So maybe for just to for refreshment, can I raise this question for the fellows? So can you list some of the risk factors for fungal sepsis in the ICU? Anyone who can mention some of the risk factors for the patient to develop fungal infection?
You can type your answers into the chat box, okay?
Okay. GI surgeries, very good. Prolonged antibiotics or previous antibiotics use, that is also right. So potent antimicrobials, immunodeficiency, lines like central line. Okay, thank you. So let's proceed. So these are some of the risk factors in addition to what you have mentioned. One is the disease severity, especially as I mentioned earlier, fungal infections was considered as a disease of immunocompromised patients, even though nowadays immunocompetent individuals are also having fungal infections in ICU. So the underlying clinical conditions is those patients with hematologic malignancies, those patients who are having BMT, I mean post BMT or bone marrow transplant, and those patients who are having other immunocompromisation scenario, like patients with HIV, those patients on high dose steroids for a longer period of time, patients on chemoradiotherapy for several malignancies. So the underlying clinical condition of the patient is one of the risk factors which predispose the patient to develop fungal infection. Previous use of antibiotics, especially in ICU, as you know, for bacterial infections or hospital-acquired infections, we are starting patients on potent and broad-spectrum antibiotics. So use of antibiotics in the previous 1 week or 2-3 weeks is one of the risk factors. And because of the disturbance, it results on also microbiota. The others are those patients on total parenteral nutrition in the ICU, recent major abdominal surgeries or GI surgeries, and those patients who have candida colonization, those in ICU, those patients on organ support like renal replacement therapy, plasma exchange, plasmapheresis, those patients who are having lines for several medical managements, those patients are at risk to develop fungal infections. So you can mention many more, but these are the common risk factors. Thank you. So let's come to our main topics for today, which are biomarkers. So these are the biomarkers are, as you know, these are the biologic markers which are either which are produced from the microorganisms and try to which helps us to identify the microorganisms itself. And these biomarkers may be available on the surface or on the cell membrane of the microbes, or on the cell wall of the microbes, or inside. So, but once they result in infection, this biologic markers will appear and elevated in the blood, serum, plasma, or other body fluids. So these are the markers which are helpful for diagnosis, specifically when we are talking biomarkers in fungal infections for the diagnosis of fungal sepsis. And some biomarkers are also very important to prognosticate the condition of the patient, whether the patient is going to have good prognosis, poor prognosis, and it will help us when we are serially monitoring their levels. The other things is for the escalation and the de-escalation of antifungals. This is for therapeutic purposes. So when the serum or blood or plasma level of certain biomarker is declining, we may need to de-escalate antifungals or stop antifungals even. Or if the level is increasing, and we may need to escalate antifungals to the level of novel antifungals. And the other thing is for conducting clinical trials, these are important markers, and since they are reproducible, and it's also identifies as the fungus or the specific fungal species which causes infection. It will also decrease your trial expense, and some of them will also be important for long-term follow-up. So these are some of the advantages of these biomarkers. And let's start with the common biomarkers that we use for some of the common fungal species, which is clinically important in the ICU, the cryptococcal antigen. So cryptococcal antigen, as we know, is important in the diagnosis and in the treatment path of cryptococcal infections, especially cryptococcal meningitis in immunocompromised individuals. So it uses the lattice agglutination or enzyme immunoassay, or it uses lateral flow assay techniques. And it has higher sensitivity, more than 95% sensitivity, and the specificity in the CSF, serum, plasma, as well as whole blood. And the importance of cryptococcal antigen is it used to detect the cryptococcal species, especially cryptococcal neoformans and the Gatti. But the problem is it will not identify or differentiate neoformans from the Gatti species. It just shows or since it is an antigen, that when the titer goes up, then there is a cryptococcal infection. Otherwise, we don't know whether it's neoformans or Gatti species, but management why there may not be a big difference between the two species, especially in terms of response to antifungals. But for a study or identification purpose, cryptococcal antigen may not identify neoformans, cryptococcal neoformans from cryptococcal gatti. So the serum or plasma level of cryptococcal antigen, especially the lateral flow assay, are more than 99.9% sensitive in detecting meningitis, especially in HIV infected patients. And the other drawback of this cryptococcal antigen is because it has false negative results, which constitute about 20% of the cases. So in about 20% of the cases, it can be result in a false negative. So if it is positive, it is sensitive and specific, so that we need to treat for cryptococcal infection. But if it is negative, we need to correlate with the clinical condition of the patient, and we need to interpret the result cautiously, because in about 20% of the cases, it can result in false negative, especially those patients with disseminated disease. So the high titers are correlated or shows the high burden of the disease, and it predicts the poor prognosis. So if the patient has high titers of cryptococcal antigen after optimum therapy for cryptococcal infection, so that is one sign of poor prognosis in such kinds of patients. So this is to just show you how how it helps us to speak about prognosis based on the cryptococcal antigen. As you can see on the lower part, the early fungicidal activity group, the number at risk is on at the lower parts of the graph. So on the y-axis, you see the survival probability, and on the x-axis, the weeks starting from the treatment. So here, as you can see, this what we call the yeast clearance rate, which is described as 0.4 or more, from 0.3 to 0.399. So this is the clearance rate. So those patients who are having early fungicidal activity or the yeast clearance rate less than 0.2, as you can see, the survival is lower. That means the mortality is quite high, the one which is described in yellow. So those patients who are having the clearance rate above 0.2, as you can see, the outcome is better. So based on when the cryptococcal antigen is positive, the other things that we need to measure together, especially when we have a good pharmacological, the clinical pharmacy, is we need to measure the clearance rate, and based on that, we can speak about the prognosis of the patient depending on the yeast clearance rate. So as I told you, those patients who are having clearance rate less than 0.2 are associated with worse outcome, which is seen with the yellow graph. So CSF 1,3-beta-D-glucan and the PCR can also be used for detecting cryptococcal infections, but when compared with cryptococcal antigen, they are suboptimal. So when we compare beta-D-glucan or PCR test for cryptococcal detection, they are inferior than that of cryptococcal antigen, especially if we are using the lateral flow assay technique, which is more sensitive for cryptococcal infection. It is more superior than that of PCR or 1,3-beta-D-glucan biomarker. So for in short, cryptococcal antigen is one of the established diagnostic biomarker, and it's also sensitive. And the lateral flow assay technique is even more sensitive than just the enzyme immunoassay cryptococcal antigen testing. And the subsequent CSF cryptococcal antigen titers shouldn't be used for monitoring a response to therapy. So once we diagnose and start patients on therapy, and especially patients are those patients who are responding, even we don't need to monitor it serially. So but sometimes we may need to do once for diagnosis and probably midway during the treatment. Otherwise, we don't need to monitor it serially for treatment response. So clinical response is more important than CSF cryptococcal antigen titer monitoring. The other biomarkers that we are going to discuss is the 1,3-beta-D-glucan biomarker. So as you know, 1,3-beta-D-glucan is it is a polysaccharide, it's a carb, which is abundantly available in the cell wall of the Candida species, Candida albicans, glabrata, cruzi, tropical, and all those Candida species. They have this polysaccharide in the cell wall. So during when there is an invasion, especially angio invasion and tissue invasion of the fungus, especially in case of deep-seated candidemia. So this cell wall constituents will express, and so positive beta-D-glucan results do not identify the Candida species, but it distinguish between the Candida or other fungi. But the only thing that it will tell is, especially the elevated, or when it becomes positive, it shows that there is a Candida infections. But which one is it? Candida albicans, Candida tropicalis, Candida glabrata, parasilosis, or which one? So it will not identify one Candida species from the other, or from even other molds or other fungi type. But the only thing that it will tell us is the presence of candidemia. So better performance is seen, especially when two or more than two sequential samples of beta-D-glucan is positive. So single beta-D-glucan sensitivity is lesser than 2 times or 3 times positive beta-D-glucan tests. So we need to, like, if we send it today and it becomes positive, at least we need to repeat and cross-check it. If in the next test it is not positive, again, we may need to do the third test, because there are some of the factors which will affect beta-D-glucagon also on top of the fungal infection. So sensitivity and the specificities, as you can see here, 75 to 80% and 60 to 80% respectively. In case of deep-seated candidiasis, that means intra-abdominal candidiasis, sensitivity is even lower, 65 to 75 respectively. So the drop in beta-D-glucan level has been correlated with successful treatment outcomes, but it doesn't mean that elevated beta-D-glucan is not directly related with worse outcome. Rather, the decrement of the beta-D-glucan with optimum treatment is correlated with the successful outcomes. So false positive can occur, as I told you, because especially as I tried to mention, single positive or elevated levels of BDG doesn't mean that patient has candidemia always, but if 2 or 3 times sequentially it is positive, definitely it is more sensitive and specific. Because these are some of the factors which will result in false positive elevated levels of 1,3 beta-D-glucan levels. Those patients who are intravenous immunoglobulin for several reasons, and those patients who are receiving IV albumin, those patients on beta-lactam antibiotics like carbapenem or the penicillin group, cephalosporins, monobactams, and the other things are those patients with some bacterial infections. These are some of the factors which will falsely elevate 1,3 beta-D-glucan as patient is having candidemia. So always we need to cross-check once 1,3 beta-D-glucan become positive at least 2 times, or we may need to repeat subsequently. So this is one of multi-center randomized control trial, which was done which was published in 2022, and this is comparing 1,3 beta-D-glucan guided antifungal therapy in adults with sepsis, fungal sepsis. So this is a CandiSep trial. It enrolled adult sepsis patients at high risk for invasive Candida infections. So these high-risk patients are those patients who were having the risk factors that we mentioned, those patients who renal replacement therapy, other organ support, those patients who have major GI surgery on potent antibiotics, immunocompromised patients, and also patients with such kinds of risk factors were enrolled. And 1,3 beta-D-glucan group received antifungals versus those patients who are taking empiric antifungals without monitoring the beta-D-glucan level. So the endpoint or the primary outcome of this study was the to measure the 28-day mortality. So when you see the result, the deaths or the mortality at 28th day occurred in 33.7% in those patients for whom antifungal treatment continued with measuring the beta-D-glucan level versus 30.5% in those patients who are just receiving empiric antifungals. So in terms of mortality, as you can see, there is no statistically significant difference between the two. That means whether we give antifungals by measuring the 1,3 beta-D-glucan level or empiric therapy according to the Candice randomized control trial. So as a conclusion, serum beta-D-glucan guided antifungal treatment didn't improve the 28-day mortality in patients with fungal sepsis. Another study from, I think this study was done in Germany. It is a case control study and comparing 1,3 beta-D-glucan, the Manan antigen, anti-Manan antibodies, and the Canditech Candida antigen tests as serum biomarkers for candidemia. Which one is better to pick serum candidemia? If we see, these are the different tests that we see here. So according to this study, the data shows that the beta-D-glucan and the Manan antigen and Manan antibody levels were significantly elevated in patients with candidemia. Probably for those of you who didn't have recent reading on this biomarkers. So Manan is again, it's a combination of polysaccharide and proteins, which is a constituent of the cell wall of the fungal species and also the penicillium bacteria. So usually when the fungus is invading the host, and this these cells are going to the mitochondria attached, so the antigen will present, and sometimes even antibody will be produced against this antigen. That is what we call anti-Manan antibody. So measuring this antigen and antibody levels will also used to diagnose the candidemia. So according to this data, which was done in Germany in 2012, the 1,3 beta-D-glucan, the Manan antigen, and anti-Manan antibody levels were significantly elevated in patients with candidemia. So the other thing is the beta-D-glucan and combination of beta-D-glucan plus Manan antigen and Manan antigen plus anti-Manan antibody showed the highest sensitivity. That means if we test only with 1,3 beta-D-glucan or doing the combination of beta-D-glucan with Manan antigen or Manan antigen with anti-Manan antibody, so the sensitivity was increasing, especially when we are combining beta-D-glucan with Manan antigen with anti-Manan antibody. So the beta-D-glucan with or without Manan antigen revealed a moderate specificity. Even if we measure only the BDG in some of the study, even it is almost equivalent as measuring or doing beta-D-glucan level plus Manan antigen or Manan antigen with anti-Manan antibody tests. So it shows that BDG has a moderate specificity and sensitivity when compared with those combination tests. So this is a summary of what we have discussed. So when we see the biomarkers, 1,3 beta-D-glucan, sensitivity to diagnose candidemia is about 87.5 and the specificity is 85.5. The Manan antigen, anti-Manan antibody, Manan antigen plus anti-Manan antibody, and the 1,3 beta-D-glucan plus Manan antigen, and the Canditech antigen test, as you can see, sensitivity is very low, 13%. But it is, if it is becomes positive, the specificity is quite good. So when you combine, let's say, do both tests, Manan antigen with anti-Manan antibody, the sensitivity increased. But if you see the specificity is not significantly increased. It is almost the same as doing only anti-Manan antibody. So by combining Manan antigen with anti-Manan antibody test, the only thing that we will increase is the sensitivity, not the specificity of the tests. But generally, the 1,3 beta-D-glucan, the Manan antigen, and anti-Manan antibodies are important tests to diagnose candidemia in the earlier time. The other biomarker is PCR, polymerase chain reaction, as you know. It offers potential advantage over beta-D-glucan or Manan antigen or anti-Manan antibody tests because it identifies targeted Candida species. Most targets are, it identifies Candida albicans, glabrata, parasilosis, Candida tropicalis, and cruzi, and the sensitivity is more than 95%. So PCR, the advantage of PCR over the other tests is specifically identify one species of Candida from the others. But if you are seeing the 1,3 beta-D-glucan and the cryptococcal antigen, whether it's a lateral flow assay or enzyme assay, and they just show you whether the patient has fungal infection or not. Otherwise, they will not identify specific organisms, but PCR does. So PCR has the sensitivity of this much and the specificity of 92%. Higher sensitivity was observed with whole blood than the serum. So in terms of sending a sample, sending whole blood is better than serum to get higher sensitivity in case of PCR. Candida or fungal specific rather than broader multiplex assays. So again, if the drawback of the PCR, especially for fungal infection, is it identifies the Candida species or specific fungus, but it is not a multiplex assay. That means it will not identify multiple. If you see the PCR in case of virus or multiplex PCR in viral infection, from a single sample, there may be a possibility of identifying 10 or 12 or 15 types of or species of virus. So still the fungal PCR may not do that much, identify that much species, but specific species that were mentioned above in the albicans, glabrata, parasilosis, Candida tropicalis, and the cruzi can be specifically identified using the PCR. The other thing is the T2 Candida test. This is again an FDA-approved diagnostic test, and it detects 5 most common Candida species. And what T2 does is it amplifies the nucleic acid, that means of the DNA. So it has a high sensitivity of 89 to 91% sensitivity. Specificity is 98, as you have seen. And for deep-seated candidiasis, that means intra-abdominal candidase infections, the specificity is lower, like 33 to 45%. Specificity is still high if it becomes positive. So positive T2 candida, but not positive 1,3 beta-D-glucan within the first 5 days after positive candida blood culture is one of the risk factors for higher mortality or development of intra-abdominal candidiasis or fungal infections. So positive PCR or T2 candida testing in patients with risk factors for candidiasis warrants enrollment in clinical trials. So this is one of the tests that is used for research purposes, especially in clinical trials. And the cultures still remain the mainstay of candidiasis diagnostics because it is more accurate, even though it takes more time. And the yields are, as we mentioned, 50 to 70%. So these are the performance of culture-independent diagnostic tests, taking positive predictive value more than 15%. As you can see, if you see the beta-D-glucan, the PCR T2 candida, and so you can see the positive and negative predictive value of each test for any patient for whom a blood culture is collected, patient in the ICU with fever, for patients with sepsis with septic shock, and for ICU patients at increased risk of candidemia based on the clinical prediction score. So you can see the positive predictive value and the negative predictive value, taking predictive positive value above 15% as clinically significant. So since I will share the slides with you, you can you will have time to see these tables in detail. But the idea is available biomarkers useful for the diagnosis of invasive candidiasis in critically ill patients are the one we're mentioning. So it is just to compare the sensitivity and the specificity plus positive and the negative predictive value of each test that was summarized from different papers. So the other biomarkers that we are going to discuss is galactomannan. Serum galactomannan is one of the common biomarkers that we use in the ICU, especially if we suspect invasive aspergillus infections or aspergillosis. So galactomannan presence in the circulation correlate with invasive growth of aspergillus. So it has a variable performance, and it is detectable in patients with hematologic malignancies and those patients who are receiving allogeneic hematopoietic stem cell transplant or bone marrow transplant shortly. And the serum galactomannan level and the survival at 42 and 118 days based on some of the studies, taking this cutoff point, especially if the galactomannan level or optical density or galactomannan index is above 2, it is associated with poor outcome. So declining serum galactomannan level is a good sign of survival or a good sign of prognosis, and persistently elevated levels of galactomannan despite the treatment is associated with poor prognosis. So galactomannan kinetics in pulmonary system or in the pulmonary fluids, including when we do bronchoalveolar lavage, is poorly understood, so it may not easily released into the bronchial fluids. And the use of serum galactomannan only in patients with hematologic malignancy and post-bone marrow transplant patients who have an elevated galactomannan at baseline is important to monitor the disease progression, therapeutic response, and prediction of the outcomes with invasive aspergillosis. This is only for those patients with hematologic malignancies and for those patients who have received allogeneic hematopoietic stem cell transplant. Otherwise, for immunocompetent individuals, it may not work for monitoring disease progression, therapeutic response, and the prediction of outcomes. So this is from American Society of Infectious Disease Guideline 2016. You can see the detail. Again, this is what we have discussed. So one of the study from Journal of Clinical Microbiology, and which shows early serum galactomannan trend is as a predictor of outcome in invasive aspergillosis. So the outcome was measured on 12 weeks. So week 12 survivors and week 12 non-survivors, if you can see. And the y-axis is, as you can see, the galactomannan index. So as the galactomannan index is going up and the weeks are going on, so the light dark one, that means at 12 weeks, those patients with galactomannan index higher at the time of admission or at the initiation of therapy have poor outcome with the p-value less than 0.003, which is statistically significant. So early galactomannan, serum galactomannan can also serve as a predictor of outcome in invasive aspergillosis. So according to this study, initial galactomannan index, as I mentioned, for selected patient have the propensity to predict not only treatment response, but also the outcome. So in general, for those patients who has risk factors and goes to infection and developed features of sepsis, and then we need to go for biomarkers surveillance. And if the biomarker is positive, so we need to start antifungal. And those patients who has infection, consider antifungals and do biomarkers. If biomarkers positive, continue antifungal. If biomarkers negative, maybe you need to go for early discontinuation for those patients who have subclinical as well as septic features with fungal infection. So as a patient is proceeding, if we don't pick it, the risk factors, we see risk factors, and we don't start antifungals earlier when we suspect infection, and we start antifungal at the sepsis level, the mortality is, as you can see, going up, and the slope is also quite steep. The other is the fundicusis is mainly the expert opinion and regarding invasive fungal disease in adult patients in intensive care unit and consensus definition. So the only thing why I bring here is the limited evidence on the performance of existing definitions and the laboratory tests for the diagnosis of invasive fungal disease other than candidiasis and aspergillosis precluded the development of shows that still we have limited evidence regarding fungal infections in the ICU, in the early diagnosis, starting therapy earlier, and monitoring the outcomes. So, and for the other molds, as I said, there are many tests left regarding for blastomyces, histoplasma infections, for coccidomycosis, mucormycosis. You can go in detail, but these are the common biomarkers that we use in practice for early diagnosis and the treatment of initiation of treatment in ICU for patients with fungal sepsis. But from those which we mentioned, the cryptococcal antigen, 1,3-beta-D-glucan, the Manan antigen, anti-Manan antibody, and the CanTech, the T2 candida tests, PCR. So which one is the best? So I don't think we have a single answer, because we need to consider, we need to see things. One is the sensitivity and the specificity of these tests. As we have seen, all of the tests have, some of the tests may have better sensitivity and specificity, but still there is no test which have 100% or nearly 100% sensitivity and specificity for all kinds of, or for most of the candida species. So that is one of the issue. The performance, some of the tests you may need to do 2 or 3 times to even make sure that patient has candidemia. Identification of species, PCR do, but still PCR is for specific groups of fungal species. Otherwise, it will not identify other all fungal species. The other tests may not identify one specific fungal types. And the serum kinetics, especially changing in, in ICU, the fluid volume and the distribution of the patient is changing, so that the condition of the microbes will also go similarly. Those kinetics will change. And some of the tests used for therapeutic purpose, some of used for clinical trials, and still there is no specific test which can work for all kinds of fungal infections. The other issue is cost, especially in resource-limited setup. The availability is a major issue. Second, if it's available, even the cost is another issue, because most of these tests will be done in the private laboratory, or even sometimes it may be sent abroad to get the result. So the cost is another issue, the delay of the result, and all those things should be taken into consideration to pick the best biomarker. So saying this, which one is best for you? I think we may discuss at the end. And so in summary, fungal sepsis is common in the ICU, and we need to have high index of suspicion, especially those patients who have high risk, who are at high risk. And culture is still the mainstay of diagnostic tool for fungal infection, and biomarkers performance varies. So we need to do serial tests, or we need to interpret results cautiously. Biomarker results should be interpreted according to the condition of the patient, the type of the tests we send, and so on. And the use of biomarkers guided de-escalation of antifungals is also one of the most important things, depending on the clinical condition of the patient we have. So these are some of the summaries. I think I'm done with my talk, and thank you.